The standard pathway to knee pain looks like this. Physical therapy, then cortisone shots, maybe a round of hyaluronic acid, the gel shots. And then when those stop working, a referral for surgery. What most patients are never offered is a step that sits right between cortisone and surgery, and it has published clinical data behind its outcomes. Today we're going to walk through what that step is, who it's right for, and just as importantly, who it isn't. Because we're going to be honest with you about where the evidence is strong and where it runs out. At Regen House, we evaluate and treat knee pain with regenerative medicine every week, and we also know exactly where the evidence is strong and where it isn't. So this is going to be the full picture: what biologics can actually do for your knee, and who is and isn't a candidate, and what a proper evaluation looks like. We'll cover the care gap, how the biologics differ from cortisone, a decision framework organized by your arthritis grade, honest candidacy, and what the evaluation pathway looks like. Let's get into it. Standard knee care has a missing step, and once you see it, you can't unsee it. Here's the pathway most patients walk. You start with rest and anti-inflammatories, the RICE approach. Then physical therapy for strength and mobility. Then cortisone shots once the pain gets limiting. Maybe a round of hyaluronic acid, the gel shots, and then when all that stops working, a referral to a surgeon. That's the standard road. The missing step is regenerative biologics. Stem cell-derived therapies and exosomes sit right in between cortisone and surgery, with published evidence at the 6 and 12-month mark. And most patients are never offered this step, simply because it isn't a part of the standard orthopedic referral pathway. Why does that gap exist? It's not a conspiracy, it's structural. Standard orthopedics is built around a surgical toolkit. Joint surgeons are trained to do surgery, and that's a different training and a different clinic model than regenerative medicine. So the referral system offers what the system has. Nobody's hiding anything. The step just lives outside the usual pathway. So here's what that means for you. If you've tried cortisone and you're now being told surgery is the next step, the step between those two options, it exists. It has evidence behind it, and it may be worth evaluating before you commit to a major procedure. First thing to understand, cortisone and biologics aren't really competing options. They're different tools that do different things. So let's compare them honestly. What does cortisone actually do? It broadly suppresses the inflammatory signals in the joint. It works fast, often within days, and that's a real strength. But the relief is typically temporary, often in the range of 6 to 8 weeks. And here's the key limitation. Cortisone does no repair signaling. It quiets the inflammation, but it does nothing to protect or rebuild the cartilage or the joint structures themselves. And there's a further consideration with repeated use. Some of the published literature suggests that repeated cortisone injections may be mildly toxic to cartilage over time. So cortisone has a real role for short-term acute flares, but leaning on it again and again as a long-term strategy is a different conversation. Now, what do biologics, things like stem cell-derived therapies and exosomes, do differently? 3 things. First, anti-inflammatory. They modulate the immune system at the joint level too, but through a different pathway. Second, chondroprotective. They carry signals that help protect the cartilage you still have from further breakdown. And third, reparative. They bring growth factor and signaling activity intended to initiate tissue recovery, not just quiet symptoms. And the durability is the real difference. For the right patient, the clinical data shows benefit sustained out to 12 months, and for some protocols, even to a 4-year follow-up. Now, the trade-off is onset. Cortisone is faster but shorter. Biologics are slower to kick in, often 4 to 12 weeks, but the durability curve is longer. This isn't about one being better than the other. It's about understanding what you need and when. Here's something almost nobody explains, and it changes how you think about every injection. Not all cartilage is the same. The cartilage that caps the bones inside a healthy joint is hyaline cartilage, and it's built largely from type 2 collagen. That smooth, gliding surface the joint is supposed to run on. Now, here's why that matters for what gets injected. When you place a biologic in the joint, the body's own repair cells migrate in, and they take their cue from the tissue that's already there. They build whatever type of collagen is most prevalent in what is put in. So, the building blocks you supply largely determine the kind of repair you get. Blood-based options like PRP carry mainly type 1 collagen. That's fibrin. So the repair they drive is mainly type 1 fibrocartilage, scar-type tissue. It can fill a defect and ease symptoms for a while, but it's mechanically inferior, and that lines up with what the research shows. Relief measured in months, even with repeat injections. The same limitation shows up with bone marrow and fat-derived options, because they're predominantly type 1 as well. Umbilical cord tissue, Wharton's jelly, is different in a specific way. It carries the full complement, type 1, type 3, and type 2 collagen. That fuller set of building blocks is what allows more comprehensive repair, including the type 2 collagen the articular surface is actually made of. That's the distinction that matters. Not just filling the gap, but supplying what the body needs to rebuild the right kind of cartilage. The right biologic depends a lot on how much arthritis is in the joint. So let's organize this by grade, because that's how the decision actually gets made. For milder arthritis, grade 1 to 2, the published evidence base for biologic injections in the knee is the most established of anywhere in the body. As one example of the category evidence, a 2024 study on platelet-based injections for mild knee arthritis reported around a 52% reduction in pain along with functional improvement sustained to 12 months. We don't offer that particular platelet-based treatment ourselves, but it's part of why the broader biologic approach for mild knee arthritis is so well supported in the literature. As the arthritis gets more involved into the grade 2 to 3 range, the more complex joint environment tends to benefit from the broader signaling capacity of stem cell-derived therapies. Multiple meta-analyses of random controlled trials have found that stem cell-derived injections produce statistically significant reductions in pain and improvement in function in knee arthritis, with the benefit typically showing up by 6 months and holding at 12. It's worth being straight that the overall certainty of this evidence is still rated as developing, and individual results vary, but the direction across the pooled trials is consistent and favorable for the right candidate. And when the durability is the priority, there's specific evidence for umbilical cord-derived biologics. A 2024 systemic review found sustained improvement out to 4 years in mild to moderate knee arthritis, and notably that multiple injections tended to outperform a single injection. That 4-year window is some of the more durable data in this space. And in some patients, depending on the full clinical picture, a combined approach, layering stem cell-derived biologics with adjunct exosomes, may be considered. That's a case-by-case decision, not a default. If you've been stuck in the cortisone loop and surgery keeps coming up, subscribe. We'll link more detailed breakdowns of each biologic option at the end of this video. And drop in the comments what you've been told about your arthritis grade, because that's the single most useful piece of information for this whole conversation. Now, the grading question. This is not a dodge or a sales filter, it's a real clinical distinction, and it's the most honest part of this whole video. Knee arthritis is staged on something called the Kellgren-Lawrence scale, 1 through 4. That keeps it simple. Grade 1 is mild with minimal joint space narrowing. Grade 2 is moderate with more narrowing and some cartilage loss. And pain is usually showing up by now. Grade 3 is significant with notable cartilage loss, reduced joint space, and more pain with activity. And grade 4 is severe, essentially bone on bone, with minimal joint space left and real structural compromise. Here's where the evidence lands. For grade 1 through 3, there's a supported evidence base for biologic treatment. And in the published data, grade 2 tends to show the greatest improvement. The strong candidate is someone with chronic knee arthritis who has failed conventional care and is active enough to genuinely benefit from getting function back. And here's the honest line. Grade 4, true bone on bone, is outside the evidence range. There's no published data supporting stem cell-derived therapies for end-stage structural joint loss. If you're grade 4, the appropriate next conversation could be a total knee replacement, and we'll tell you that directly. This isn't a sales decision, it's a clinical distinction based on what the published evidence actually supports. But here's the flip side of that, and it's important. We sometimes have people come in who were told they're bone on bone, grade 4, that they need a complete replacement, and then when we look at the actual imaging, that's not exactly what we're seeing. They're not grade 4. So before you commit to a major surgery, please, at the very least, get another opinion and confirm the grade. Make sure the picture you're being told matches the picture on the film. A second look costs you very little, and a knee replacement is permanent. And one more thing on grade 4, because I don't want to leave anyone feeling like they're out of options. If you genuinely are bone on bone, but you're not ready for a knee replacement, or it's just not the right time in your life for a major surgery, that's a real situation and it deserves an honest conversation. Here's the honest version. We're not going to tell you a biologic is going to rebuild a joint that's down to the bone because the evidence doesn't support that. And we won't pretend otherwise, but a biologic works in part by calming the inflammation inside the joint, and for some people that can take the edge off the symptoms, even when the structure itself isn't changing. That's a different goal than repair. It's about comfort and function, not rebuilding the joint. So if you're grade 4 and surgery isn't where you are right now, it's still worth a conversation as long as you go in with clear eyes about what it can and can't do. A few other things factor into candidacy too. Your prior treatment history and how you responded. Your functional goals, what success actually looks like for you, and your overall health and metabolic environment, because that shapes how well your body can respond to any biologics. Let's make this concrete because most people have never been told what actually happens. The evaluation has a few parts. An MRI review to confirm your arthritis grade, a functional assessment looking at range of motion, strength, and your pain pattern, a review of your prior treatment history and how you responded, and then a candidacy determination and protocol design built around all of that. When you come in for a consultation, bring your imaging, your most recent MRI, ideally within the last 12 months, and any x-rays that show the weight-bearing joint space. That's what lets us grade the joint accurately. As for the treatment itself, the injection is office-based, ultrasound-guided, and you go home the same day. Most responsive patients start noticing something in the first 4 to 8 weeks. Peak improvement usually lands around 3 to 6 months. And the durability, as we covered, is consistent at 12 months with 4-year data available for specific protocols. And then there's the follow-up, because this isn't a one and done and forget it. There are typically check-ins along the way, and if your initial response is only partial, the protocol can be adjusted from there. So here's the whole picture. Between cortisone and surgery sits a clinical pathway that most pain patients are simply never offered. For grade 1 through 3 arthritis with failed conventional care, regenerative biologics have published evidence for meaningful, durable improvement in pain and function. The right biologic depends on your grade and your goals. And the honest line stays the honest line. Grade 4 bone on bone is outside the supported evidence range. And that's where surgery is the right conversation. But if you're grade 1 through 3 and you've tried cortisone without lasting relief, you now know exactly what to ask before committing to surgery. So here's our question for you. Have you tried cortisone shots for your knee? If so, how long did the relief actually last? Drop it in the comments. We read them, and it helps us decide what to cover next. If you want the detailed breakdown of how stem cell-derived biologics and exosomes compare specifically for knees, we have a video on that and we'll link it right here. And if you want the full evidence review on stem cell-derived therapies for knees, the outcomes, the grades, the cartilage question, that one's linked too. Subscribe for the clinical clarity that makes the next decision easier. We'll see you in the next one.